Welcome to This Week in Anesthesiology. This week we are covering 7 notable papers spanning 3 major themes: optimizing perioperative recovery pathways and regional blocks, comparing monitoring modalities and anesthetic techniques in high-risk cardiovascular procedures, and managing postoperative neurological and acute pain outcomes. Let us dive in. We begin with a look at how we can systematically optimize recovery, from broad institutional guidelines to specific regional anesthesia techniques. Researchers conducted a systematic review of 24 enhanced recovery after surgery society guidelines to identify a universal anesthesiological core across various surgical specialties. Using a Delphi consensus to develop 45 anesthesiological umbrella terms, they identified 8 domains that were highly consistent, appearing in more than 80% of the guidelines. These core domains include multimodal analgesia, fasting, thromboprophylaxis, antimicrobial prophylaxis, perioperative nutrition, temperature management, fluid management, and surgery-specific recommendations. The authors suggest that while these high-frequency areas represent the baseline of standard care, mixed-strength domains like preoperative carbohydrate administration and pre-anesthetic medication require structured local appraisal to fit specific institutional workflows. This systematic approach highlights that while surgical procedures differ, the core tenets of anesthetic care remain highly unified. This focus on standardized recovery pathways connects directly to a massive target trial emulation study also, which evaluated whether combining regional and general anesthesia actually translates to better functional recovery. Researchers analyzed database records from over 670,000 adult patients undergoing major orthopedic surgery in Japan. They compared combined general and regional anesthesia against general anesthesia alone, using propensity score weighting to ensure comparable baseline characteristics. The investigators found that patients receiving combined anesthesia had a statistically significant, though clinically modest, improvement in their Barthel index scores, which measures activities of daily living functional change from admission to discharge, with a mean difference of 0.73. Furthermore, combined anesthesia was associated with a shorter hospital stay by 1.4 days and a lower risk of in-hospital mortality, with a hazard ratio of 0.85. While the authors caution that residual confounding and the wide variety of regional techniques used require prospective validation, these real-world data support the clinical benefit of incorporating regional blocks into major orthopedic cases to enhance physical rehabilitation. When it comes to selecting the specific regional techniques for these major joint surgeries, the updated prospect guidelines for total hip arthroplasty provide highly practical evidence-based recommendations. After reviewing over 100 randomized controlled trials and systematic reviews published between 2020 and 2024, the expert panel maintained its core recommendations of scheduled paracetamol and non-steroidal anti-inflammatory drugs, combined with a single intravenous dose of dexamethasone of 10 mg or less. For regional techniques, the update now preferentially recommends either a supra-inguinal fascia iliaca compartment block or a preoperative pericapsular nerve group block, commonly known as a PEENG block, because they provide the most consistent analgesia. In contrast, the guidelines explicitly advise against quadratus lumborum and lumbar erector spinae plane blocks due to inconsistent efficacy and an increased risk of motor weakness. If these preferred regional techniques are unavailable, a single-shot local infiltration analgesia remains a suitable alternative. This guideline provides clear direction for clinicians looking to maximize pain relief while preserving motor function for early mobilization. Moving from orthopedic recovery to cardiovascular and non-cardiac surgical care, our next papers examine the tools we use to monitor hemodynamics and the anesthetic choices we make for high-risk procedures. Accurate blood pressure monitoring is essential, and a prospective method comparison study published in the British Journal of Anaesthesia evaluated whether non-invasive finger cuff systems can safely substitute for invasive monitoring. In 76 patients undergoing low to moderate risk non-cardiac surgery under general anesthesia, researchers compared simultaneous measurements from a finger cuff system, standard upper arm oscillometry, and an intra-arterial catheter, collecting over 2,500 measurement triplets. For mean blood pressure, the finger cuff showed a mean difference of -2.8 mm of mercury compared to the intra-arterial gold standard, while the standard oscillometric cuff showed a mean difference of 2.1 mm of mercury. The limits of agreement were comparable between the two non-invasive methods. This suggests that for low to moderate risk surgeries, continuous finger cuff monitoring provides a level of agreement with intra-arterial lines that is highly comparable to traditional intermittent oscillometric cuffs, offering a continuous monitoring alternative without the risks of arterial cannulation. This question of monitoring and invasiveness extends to the choice of anesthesia for transcatheter aortic valve replacement, or TAVR. A real-world target trial emulation study published in the Journal of Clinical Anesthesia used a global collaborative database to compare general anesthesia with non-general anesthesia, which included regional anesthesia or sedation, in over 3,500 propensity-matched patients. The study found no significant differences between general and non-general anesthesia in terms of all-cause mortality or major complications, including stroke, myocardial infarction, acute kidney injury, or respiratory failure, at 30, 90, or 365 days. Interestingly, patients who received general anesthesia had a nominally higher rate of heart failure at 1 year, with a hazard ratio of 1.44, while the non-general anesthesia group experienced fewer all-cause hospital readmissions within 30 days post-procedure. These findings suggest that while long-term safety profiles are largely comparable, avoiding general anesthesia for TAVR may offer modest benefits in early healthcare utilization and reduce early readmissions. Our final theme addresses the challenging postoperative recovery phase, focusing on cognitive complications in older adults and pain patterns in pediatric patients. In the geriatric population, postoperative delirium remains a major concern, and a randomized non-inferiority trial published in Anesthesia investigated whether the ultra-short-acting benzodiazepine remimazolam is a safe alternative to propofol. In 455 patients, aged 65 or older, undergoing lung resection surgery, the researchers hypothesized that remimazolam would be non-inferior to propofol regarding delirium incidence during the first 3 postoperative days. However, the trial failed to establish non-inferiority. Delirium occurred in 48% of patients in the remimazolam group, compared to 31% in the propofol group. This absolute risk difference of 16.5% far exceeded the pre-specified 10% non-inferiority margin. The difference was primarily driven by emergence delirium in the post-anesthesia care unit, which affected 46% of the remimazolam group, compared to 28% of the propofol group, whereas delirium rates after discharge to the ward were low and similar between groups. This trial signals that despite its favorable pharmacokinetics, remimazolam significantly increases the risk of emergence delirium in older surgical patients compared to propofol, and should be used with caution in this vulnerable population. While older adults face cognitive challenges, pediatric patients continue to suffer from high rates of undertreated acute pain, as highlighted by a prospective cohort study. Drawing data from the International Pediatric Pain Out Registry, researchers evaluated over 2,000 patients aged 4 to 18 who underwent various surgeries. A striking 79% of children experienced moderate to severe pain on the first post-operative day. The study revealed clear age-related patterns, with pain intensity increasing with age and peaking around 12 years, particularly in girls. Regression analysis confirmed this age-related pain increase in females, showing a significant interaction coefficient of 0.08. The lack of regional anesthesia and undergoing appendectomy were also strong predictors of higher pain. Older children aged 12 and above received significantly higher doses of oral morphine equivalents for appendectomy and spine surgery, though doses were comparable between sexes. These findings highlight a critical gap in pediatric pain management and suggest we must tailor our analgesic strategies to account for developmental age and sex-related differences, especially around the onset of puberty. If you only have time for one paper this week, make it the updated prospect guidelines for total hip arthroplasty. This work provides clear, highly actionable guidance on which regional blocks to prioritize and which to avoid to optimize both pain control and motor-sparing recovery in our daily practice. Here are the key takeaways from this week in anesthesiology. First, for total hip arthroplasty, prioritize suprainguinal fascia iliaca or PEN blocks and avoid quadratus lumborum or lumbar erector spinae plane blocks due to the risk of motor weakness. Second, avoid using remimazolam as a primary anesthetic in older patients undergoing thoracic surgery, as it significantly increases the risk of emergence delirium compared to propofol. Third, combining regional anesthesia with general anesthesia in major orthopedic surgeries, is associated with modest improvements in post-discharge functional recovery, shorter hospital stays, and lower in-hospital mortality. Fourth, non-invasive finger cuff blood pressure monitoring provides a level of agreement with intra-arterial lines that is comparable to standard oscillometric cuffs, offering a viable continuous monitoring option for low to moderate risk surgeries. Finally, recognize that nearly 80% of pediatric patients experience moderate to severe postoperative pain, which peaks around age 12, especially in girls, requiring more aggressive age-targeted multimodal analgesic strategies. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.